My name is Sally Graglia. It is such an immense pleasure to be here talking to you about one of the things that I love most, which is point-of-care ultrasound in resource-limited settings. And it turns out that whenever I do any sort of talk when it comes to point-of-care ultrasound, my goals are always the same. My goal is to inspire a love affair between you and point-of-care ultrasound and to generate increased awareness about the unlimited potential of point-of-care ultrasound in low-resource settings. Of all the cases that I'll be sharing and reviewing very briefly with you today, these cases came from my previous work in Liberia. So just for reference, this is Liberia on the west coast of Africa. Those dates again were 1822. The American Colonization Society started having people settle in Liberia in 1847. Liberia declared independence. Liberia is absolutely stunning. This is an image off the coast at one of the restaurants. It's an incredibly vibrant culture full of lapa, which I'm trying to demonstrate today. And there's many tribal identities and there's a beautiful diversity of culture. The food is phenomenal and overall Liberia is just an incredible place. This is the Ducor that I was speaking about, this photo again from the 1970s. It was one of the only five-star hotels on the continent of Africa for a long time, and it was where dignitaries would come and also Liberian families with means would go to enjoy the holidays. This is the Ducor today. So I trust people can see my slides now and appreciate the difference between the Ducor then and the Ducor now. So this is where I really kind of try to establish just the understanding of how things have changed in Liberia. And again, 1980 to 2003, 23 years of instability, 14 years of violence, and 2 civil wars. Many Liberians fled Liberia who had any means or any connections outside the country. That left a country with a very weakened and vulnerable healthcare system, with only 51 physicians for a population of almost 4 million in 2006. And then again, March 30th, 2014, this is when Liberia confirmed its first 2 cases of Ebola. This is a map from the region about a year later, and I hope you can appreciate in the bottom left corner, Liberia not only had the highest incidence of cases, but it also had the highest mortality associated with Ebola. From around the same time, in May of 2015, Liberia had lost 0.1% of its entire population to Ebola, and that translated to a 10% reduction in physicians in the country. Point-of-care ultrasound is absolutely critical in my environment where I work in a high-resourced environment in San Francisco. And POCUS has an even more critical role in low-resource environments like this, where there may not be any advanced imaging available, and not only not advanced imaging, but also no specialist to interpret those images. So, using POCUS in environments like this is critically important, and it's important to be comfortable with all the core applications as defined by ACEP. This is a positive FAST that is used in trauma. This was a patient with dilated cardiomyopathy postpartum, so postpartum dilated cardiomyopathy. And this is a patient with aortic dissection. All of these patients were from low resource environments. And it's absolutely critical to be comfortable with those core applications in order to adapt those applications for other indications in these low resourced environments. So I just want to go through several cases that I think make point-of-care ultrasound just shine in its utility. This was an 11-year-old who presented with fever, fatigue, and weight loss, and their exam revealed palpable abdominal masses. Obviously, the differential diagnosis is huge for this. Here, what we're looking at is, with the curvilinear probe in the transverse orientation, kind of across the upper abdomen, we're looking at the liver parenchyma in the top left, the aorta, this anechoic circular structure here, sitting on top of this hyperechoic and shadowing spine. There are several little lesions that come and go right here. Do you see how they come and go? You can see them and then you can't see them anymore. Sonographers might refer to this as blinking, because what's happening is as you move your probe over the structure, you can't see anything, can see something, and then can't see anything anymore. This is using the linear probe to interrogate the spleen, and I hope you can appreciate the heterogeneous, or this kind of irregular appearance of the spleen. Here's another zoomed in example. We call these microsplenic abscesses, And actually, this was an example of a positive FASH. The FASH is focused assessment with sonography in HIV and TB, and basically is like the FAST, except you also add a view looking at the aorta for peri-aortic lymph nodes. This literature from Patel et al. Showed that splenic lesions plus lymph nodes around the aorta had an odds ratio of 2 for abdominal tuberculosis. So many of us likely think about TB as a primary lung disease. However, hematogenic spread can affect any organ system, and TB can have a very varied presentation. For a lot of reasons, including pathology, this is difficult to diagnose in low resource settings, and ultrasound is one of the best modalities to do so. In our environment in Liberia, we were unable to get confirmatory tests for TB in this patient. They were initiated on anti-TB medications and were followed in the outpatient setting. This next case is near and dear to my heart. This was a 4-year-old who had fallen from a tree with concern for peritonitis. The providers were appropriately concerned that there was intra-abdominal pathology, so we did a FAST exam. And this is actually what we saw. To orient you, this is again the curvilinear probe. The indicator here is actually pointing towards the patient's head. We're in the coronal orientation. And this is the diaphragm here that's moving up and down with breath. This is the vertebra or the spine. This is the patient's liver. And I hope you appreciate how big and bright this kidney appears. Fortunately, this FAST exam was negative for free fluid, but we were so concerned about this big, bright kidney. The FAST was negative. The patient went to the OR for an X-lap. That was negative. An HIV test was recommended by our team. It was ordered and was positive. Whenever you see a big, bright kidney on ultrasound, please consider HIV nephropathy, as this child had. Another good infectious disease case. This was a 40-year-old male who presented to the hospital and was actually admitted to the surgical service with left flank pain, a fever of unclear etiology, and tenderness to palpation of his left flank. The surgeons planned to take him to the OR to do an exploratory laparotomy and get down to the bottom of his pain, and asked us to do a point-of-care ultrasound. This is something I've never seen in the United States before, but basically what we're looking at here is, again, we're using the linear probe. All of this is subcutaneous fat. There's actually a layer of muscle down here. And I hope you can appreciate that right here, this layer is very homogeneous and it's behaving like fluid. You can kind of squish or compress it out of the way. Here's another clip of the same patient. It's a little more subtle because we're applying less pressure, but I hope you can appreciate that this segment here is moving. It's like fluid. We diagnosed this patient with pyomyositis. Again, something I've never managed in the United States, but this patient had complete conversion of a muscular compartment to pus. And this patient was continued on the antibiotics that they had been started on. They had an IND performed at the bedside, and we prevented the morbidity and mortality associated with going to the OR in this environment. I think this is my last infectious disease case, and then I'll take some questions. The next patient was a 56-year-old male who presented with belly pain, nausea, and fevers, again of unclear etiology, and he had right upper quadrant tenderness to palpation. My trainees appropriately wanted to investigate his abdomen with ultrasound, and this is actually the same view. This is the right upper quadrant. This hyperechoic line that's moving with respiration is the diaphragm. Here is the spine. You can see that beautiful scalloping and shape of the spine. This whole organ is the liver. And so I hope you can appreciate that this tissue in here looks a little heterogeneous and a little irregular. We then looked at the liver in the transverse view. So this is actually similar to that patient who had the peri-aortic lymphadenopathy. This is all liver tissue. Here's the aorta, just deep to the liver, and here's the vertebral body. What we were seeing before in that right lobe of the liver is over here. That kind of irregular ratty appearance, and then an anechoic center. And also here, we're seeing total transformation of the liver tissue, and you see that heterogeneous circular appearance. This patient had liver abscesses. Apparently, liver abscesses are the most common type of visceral abscess. And pyogenic liver abscesses can either be directly inoculated or hematogously spread. There's no randomized controlled trial for antibiotics as a primary treatment, and it's recommended to consider surgical drainage if there's multiple abscesses, if they're loculated, or if they don't respond well to a percutaneous drain. Again, this gentleman had 2 percutaneous drains placed under ultrasound guidance, and he was started on antibiotics, and he did very well and was discharged without need for surgery. So Jay, are there any questions so far in the comments? I'm not hearing anything. So I guess I'll just continue and I'll ask you to interrupt me if there's any. I don't think anyone can speak about point of care ultrasound in lower resource environments without speaking about patients with a uterus. This was a 24-year-old female who presented for evaluation of pelvic pain, abdominal pain, and vaginal bleeding. This was a curvilinear probe in the right lower quadrant, and obviously we can see wiggles. So wiggles would be very exciting in a patient with an anticipated and desired pregnancy. However, I trained my trainees in Liberia well to actually start over the uterus. So what you're seeing here is actually, this is the uterus in a longitudinal view posterior to the urinary bladder. This is the endometrial stripe, and what I hope you can appreciate about this is that wiggles is not inside the uterus. So as we fan away from the uterus in the midline, we actually see wiggles in the right lower quadrant. Obviously, if this had been undiagnosed, this would have been catastrophic. This patient had an ectopic pregnancy that was actually several weeks along. The patient did well, went to the OR and had removal of the adnexal ectopic pregnancy, leaving her with 1 ovary, and she did very well post-operatively. This was a very, very sad case. This was a 27-year-old female, as you can see, G4P3 at 37 weeks, who presented with no fetal movement. One of the wonderful trainees that I worked with, Dr. Wahil, wanted to use ultrasound to confirm that there was no fetal movement. Using M mode placed over the fetal heart, we did confirm that there was no fetal movement. But then something caught our eye. We moved our probe cephalad toward the top of the fundus, and we saw this kind of like dilated area of amniotic fluid. And looking through the fundus of the uterus, we appreciated this. So this can be a very discombobulating image, especially for anyone, but especially if you may not be as familiar with the OB-GYN or point of care ultrasound. But essentially what's happening here is that this, in the beginning of the clip, this is the fundus of the uterus, and that's the placenta. This is a fetal leg. This is a fetal femur and fetal parts extending through the fundus of the uterus, and the amniotic sac is still intact. This patient had uterine rupture of the fundus of her uterus. There are many risk factors for uterine rupture, and she, having 3 previous children, some of whom were cesarean section, was at risk. Fortunately, instead of inducing labor in this patient, she went to the OR where a fetal demise with uterine abruption, but an intact amniotic sac was confirmed. Also, when speaking about point of care ultrasound in lower resource environments, I've adopted the term indication creep. I would seldomly ultrasound a 22-month-old eyeballs in the emergency department where I work, but this child was sent to us at the hospital with concern for preseptal cellulitis because they had no appreciated red light reflex. For context, this is an image of what a normal ocular ultrasound might look like. If you can imagine in a compliant patient, you have them close their eyes, you place the probe over their eye, and you're looking through the closed eyelid, which is up here at the surface, through the vitreous-containing posterior cavity of the eye, and you're actually seeing some shadow from the optic nerve there. In this child, because they were 22 months old, we actually got away with putting our ultrasound on the temple because they weren't fully calcified, so we could see through it. And instead of a nice anechoic-filled orbit, we saw this. To compare it to the other side, we placed the probe in the same location on the other temple, and we unfortunately saw this. This first image shows a posterior cavity of the eyeball that is completely occluded by heterogeneous substance. And this eye shows probably the growth of the substance, but it's not yet as far along as the other eye. The pediatrics team was very concerned about retinoblastoma in this patient and tried to arrange treatment. Another case that made me incredibly uncomfortable was there was a 3-week-old patient who was having persistent jerking or convulsions or seizure, brought in with fever and no improvement of mental status after many days of antibiotics with a bulging anterior fontanelle. The providers asked me to perform an ultrasound of this patient. I was not excited because that's not something in my repertoire generally as a general emergency physician. But again, placing the probe over the anterior fontanelle, that gives you an acoustic window to look into the brain, at the brain tissue. This is a normal appearing neonatal brain. This is the falx in the center. I hope you can appreciate kind of the appearance of what you imagine brain tissue might look like. And these are the 2 slit-like ventricles. Unfortunately, our kiddo had this. I hope you can appreciate how different this is. And just to give you some sense, this is the skull. So that's the anterior calvarium. This is that falx. And these are 2 tremendously dilated ventricles. This patient had ventriculomegaly, and unfortunately we didn't have access to the neurosurgeon in the country at that time. There's one Liberian neurosurgeon, and they were able to use that ultrasound as a prognostic tool for the clinical team. I saved one of my favorite patients for last. This was a 12-year-old presenting with right buttocks pain and spasm of the right lower extremity for the past 2 days after she'd received an injection into her buttocks. At the time, I was working with an absolutely brilliant and wonderful interventional radiologist who was also in Liberia. We put the ultrasound probe on, and just for context, this was her left buttocks on the left side of the screen, so her unaffected buttocks was relatively normal. This is fat. This is probably her gluteus maximus. And what you might appreciate over here is you've lost all of that regular structure of the muscle. And instead, what you're seeing looks much more like lung. So at the bedside, the first thing out of my mouth was, this is air, this is necrotizing fasciitis. And the brilliant interventional radiologist next to me was like, no, look at the other glute. And so we did. And ultimately, I convinced him that this was free air in the skeletal muscle. The patient went to surgery with the team, and the surgery team reported a gush of air and this dish soap appearing fluid along the fascial plane, consistent with necrotizing fasciitis. She did so well, and she was ambulatory on the pediatrics floor. Her spasms improved, and she was able to be discharged home. Ultrasound is valuable in any setting. But in settings like Liberia, where I had the privilege of working, in the hands of the providers, ultrasound can be used to be performed and interpreted at the bedside. So thank you very much for your time. This is my email. Please don't hesitate to reach out with questions, and I will stop so that I can take questions. How did you set up this rotation? So thank you. I don't even know the participants' comfort with point of care ultrasound. So also, if people wouldn't mind writing, are you novice with point of care ultrasound? Are you so much more senior than me that you're going to correct all of my slides? If people could please write in the comments, just give me a sense of where you are in your ultrasound experience. And Rita, I will answer your question. Meanwhile, so this was not a rotation. This was an experience that I was very, very privileged to have. And it was actually a job offered to me at ACEP in 2016 when I was a fellow. So I trained at UCSF. I did fellowship at Mass General Hospital. And through my experience at Mass General, I got connected to wonderful mentors, one of whom is Trish Henwood. Trish Henwood created an organization called PURE, which is Point of Care Ultrasound in Resource Limited Environments. And through PURE, I was offered the full-time position of living in Liberia and training an interdisciplinary cohort of residents. And so all of these cases were from my experience working and living in Liberia, training exceptional physicians from pediatrics, internal medicine, OB-GYN, surgery, and family medicine. Great question, Rita. What do you believe are the biggest barriers to changing practice in these areas? We now have great accessible probes that can go everywhere, like Vave. What else is needed? So Renee, that's a really, really wonderful question. I give so much credit to the mentors, the phenomenal women and men who trained me in point of care ultrasound and put me in a position to be an educator. I think one of the things that was stressed to me by one of my mentors, who is at Boston Children's Hospital and the head of global health there, was that obviously as physicians, as providers, our first mantra is do no harm. And it is concerning to me sometimes that in environments, if a provider has access to a probe, but doesn't have the education, competence, and confidence to appropriately utilize that technology, I do think that that is a concern. And I also recognize my bias as an educator and someone who's very enthusiastic about the potential of point-of-care ultrasound in these settings. But I think that accessibility to this technology needs to be coupled with comprehensive training. And comprehensive training doesn't necessarily mean going in for one episode, one training, one afternoon, 1 week. I think comprehensive training needs to be coupled with QA opportunities, quality assurance, and making sure that when providers have questions, they have people that they trust that they can go to. And I think that with technology, it's incredibly inspirational. And I know that I serve as one of the mentors for a resident in Rwanda and give her feedback on her studies. But I do think there needs to be an intentional effort to make this education comprehensive and to bridge providers who may not have a lot of experience with people who can share their experience and expertise. Ash, I'm seeing a question from you. So what are the challenges with some of the POCUS devices that you found during your practice? Woof. So many. So obviously in any environment, it's critical to keep your devices clean. In an environment that had previously had Ebola outbreaks, I really wanted to be mindful and very intentional about the reality that ultrasound machines could be vectors for disease transmission. So number one, I think that these devices have to be durable. They have to be easily cleaned and easily prepped for the next patient to prevent them becoming a transmission device. Also, it was very important to have a portable machine, a machine that could be rolled down the ramp to get to the emergency department, the kind of medicine side of A&E and the surgical side of A&E, or for OB-GYN for the interface where patients presented or labor and delivery. So I do think these machines have to be durable, as I said, for both cleaning. They have to be portable. They have to be easily transported. To plant the seed in your mind, Ash, I do think that machines that are portable need to have some way of tracing or some way to prevent them from walking away from the hospital. Even the most well-intentioned clinicians can take things away, and so that may be something you need to think about. We locked our machines to a portable tray so that they would have to physically stay in the hospital. Other challenges, humidity is a big challenge for a lot of different machines. Many machines, you kind of change the probe by changing them in and out of the machine itself, and humidity could cause some erosion on the computer interface. So Ash, that's a wonderful question, and I hope I adequately answered it. Thank you so much for your time and engagement.